Superior vena cava syndrome is a new high-yield fact for 2012. We mentioned this as an earlier potential complication of lung cancer as part of that sphere mnemonic. This basically occurs when you get obstruction of the superior vena cava. In this chest x-ray, you can see the lung cancer, which is compressing the SVC. So what would you expect because of this? Since you're blocking venous return from the upper part of the body, you may see facial swelling or plethora, as well as JVD and upper extremity swelling. You can also get shortness of breath, headaches and dizziness, and rarely cerebral edema, aneurysm, or brain bleed. Here's a picture of a patient with SVC syndrome with facial swelling, as you can see here, which resolved later in the day. You can see the fullness of the face, especially on the eyes, at the mouth, and the contrast is pretty clear when you compare it to what his face should be looking like. Because this is most commonly caused by tumor, namely bronchogenic carcinoma, you're going to see this in what type of population? Older folks. If you saw this in younger folks, you may think of lymphoma or leukemia or possibly infectious like TB in rare cases. Thrombosis can also be a cause, secondary to what? Well, any type of coagulopathy or maybe a central venous foreign body like a catheter, pacemaker, or guide wire. This condition is usually treated with steroids, diuretics, as well as surgery, radiation, and chemotherapy directed towards the lesion. You may also consider an endovascular shunt. Anatomically, you can think of infectious pneumonia as lobar bronchial pneumonia or interstitial. Lobar pneumonia is characterized by an intraalveolar exudate that leads to consolidation, potentially of an entire lung. The most implicated organs in the outpatient setting are strep pneumo and occasionally Klebsiella. Here is an example of lobar pneumonia in the right lung. And it's in what lobe? Obviously it's not the right lower lobe because you can clearly see the right hemidiaphragm. So is it the right upper or right middle? Well, it's going to be the right upper because this whole lower area where the right middle lobe would be is clear. Here's an example of that right middle lobe lobar pneumonia that I showed you on the respiratory anatomy talk. Even though it's in the right lower part of the lung, you can clearly see the right hemidiaphragm. So bronchial pneumonia is characterized by acute inflammatory infiltrates from the bronchioles that extend into the adjacent alveoli. Typically, you'll see patchy infiltrates on chest x-ray that involves more than one lobe. Here's a histopath image showing neutrophilic infiltration into the alveolar spaces. The infiltrates can also consolidate, as seen in this gross specimen. These are some of the typical bugs that can cause bronchial pneumonia. With staph pneumonia, what are you thinking? You're typically going to find this as a complication of the flu or viral pneumonia. You'll also see this in IV drug users, hospitalized patients, old folks, and folks with chronic lung diseases like COPD. Where do you find H-flu pneumonia? Usually in babies and young children, though you can also see it in adults with COPD and other lung conditions. What about Klebsiella? Think diabetics, alcoholics, and the elderly, basically immunocompromised people. Remember, of course, the red currant jelly sputum that we talked about in the micro chapter. I'll also throw in Moraxella catarrhalis, which you can see in the elderly and patients with COPD. Finally, it's worth mentioning a few specific bronchial pneumonia types like aspiration pneumonia. Aspiration pneumonia involves what type of bugs? Well, since it's aspiration, you'll probably see gram-positive or gram-negative anaerobes from the mouth. The pneumonia will also be located in the more dependent segments of the lung. Then there's ventilator-associated pneumonia, or VAP for short, which is something we often see in intubated patients. This is a bronchial pneumonia frequently caused by staph, as I mentioned, and also Pseudomonas aeruginosa. When you have a patient with a non-productive cough with fever and shortness of breath, you may want to think about an interstitial or atypical pneumonia, which is commonly caused by viruses, Mycoplasma, Legionella, and Chlamydia. Mycoplasma, in particular, tends to occur in what populations? Older children and young adults. As you can see here on chest x-ray, you tend to see a diffuse patchy inflammation localized to the interstitial areas at the alveolar walls. You often hear this pneumonia referred to as a walking pneumonia. Why is that? Well, that's because it tends to have a more indolent course than other types of pneumonia. Legionella is a gram-negative rod that's associated with what? aerosol from contaminated water sources, including cooling towers and large air conditioning systems. It causes, of course, Legionnaire's disease. The milder flu-like form is called what? Pontiac fever. Legionnaire's disease can be deadly if not treated with a macrolide or quinolone. Chlamydophila pneumoniae is a common cause of community-acquired pneumonia. But what if I told you that a patient working at a pet store comes to you with signs of atypical pneumonia? Well, then you would probably think of psittacosis, also known as parrot fever, which occurs secondary to transmission from pet birds like parakeets, parrots, and cockatiels. Lung abscess are most often due to aspiration of mouth anaerobes. You can also get it from bronchial obstruction, such as lung cancer. In general, these folks are sick, malnourished, older, or debilitated in some way. As I mentioned, the typical bugs are anaerobes like Peptostreptococcus, Bacteroides, and Fusobacterium, and they typically respond to clindamycin. Aerobic bacteria like Staph, Strep pyogenes, and Klebsiella can also lead to lung abscess, especially in what setting? That would be a hospitalized patient with aspiration pneumonia. And here you would probably add a cephalosporin or ampicillin plus sulbactam. Finally, don't forget that fungi like Aspergillus and Candida can do this, as well as parasites like Entamoeba histolytica. Hypersensitive pneumonitis is also a new first aid fact for 2012. This is a delayed hypersensitivity reaction to some environmental exposure, such as aerosolized mold or droppings, leading to an IgG type 3 hypersensitivity reaction and a CD8 positive lymphocyte type 4 hypersensitivity reaction in the alveoli. This is not a type 1 hypersensitivity reaction like you can see in asthma and allergies. And also, unlike asthma, the inflammation is more centered in the alveoli as opposed to the bronchi. Symptoms usually show 4 to 6 hours after exposure, and you can get shortness of breath, a dry cough, chest tightness, headache, and a fever. You may also hear bibasilar dry rales and see a decreased diffusion capacity, or DLCO. If you look at the chest x-ray, it may look a bit like atypical pneumonia or interstitial lung disease. On histopath, you're going to see this chronic interstitial inflammation that consists primarily of lymphocytes as well as some of these granulomas. In the hypersensitive pneumonitis condition called farmer's lungs, what's the exposure? Well, it's usually secondary to thermophilic actinomyces bacteria like Saccharopolyspora recti virgula. Saccharopolyspora recti virgula. And occasionally Aspergillus fungi, which you can find in moldy hay and compost. And what about bird exposure? Well, this is called bird breeder's lung, or bird fancier's lung, and this is due to the exposure of avian proteins in the dried aerosolized bird droppings. Keep in mind, this is not psittacosis, which we just talked about, where you have a true bacterial pneumonia. There are many other work exposure conditions related to hypersensitive pneumonitis, like malt worker's lung and cheese worker's lung, but farmer's lung and bird breeder's lung are the most common and most likely to be tested. You can treat these patients with steroids, but the main treatment strategy is antigen avoidance.